I'm going to present on work I did with a number of psychologists across the nation, where we were looking at pediatric consultation liaison psychology services during the initial phases of the COVID-19 pandemic in the US. The main aims of the presentation will be to introduce the historical origins of pediatric psychology consultation liaison care and the challenges that were faced early on in the pandemic, to describe the national study we did to capture how psychologists were adapting to this health service changes that were required during this time, to present qualitative and quantitative findings, and then to discuss future directions for the field of pediatric consultation liaison psychology. Pediatric CL psychology is a fairly young field. It developed in the 1970s out of the recognition of a growing need for psychology services in medical settings to address the psychological factors that were affecting children who either had medical conditions or that were who had medical conditions. And as opposed to traditional psychotherapy, pediatric CL psychology tends to be more brief and very focused on a specific problem or intervention. There are 7 key components of this form of practice. This includes crisis management, helping children and family cope and adapt to the medical conditions and treatment they're undergoing, improving compliance or adherence to medical regimens, communication, both with the family as well as with the medical team, collaboration with family as well as the consulting teams, dealing with the changing systems and helping families understand and navigate that, and champion both the family's rights within the medical field, but also the importance of assessing and addressing behavioral and mental health concerns in this setting. Early on in the pandemic, it was sort of understood or known that there were likely going to be mental health sequelae of what was happening. If we look back historically in other pandemics or epidemics, mental health has been a key concern. Preliminary studies during COVID-19 were showing elevated mental health symptoms in other areas of the world that were affected earlier than the US were. They were also showing that individuals who were either directly impacted by COVID-19 or who were at increased risk due to pre-existing conditions such as immune compromising conditions were also at increased risk for maybe both for COVID-19 infection, but also for experiencing elevated mental health symptoms. And they were really reporting mostly elevated rates at that time of anxiety and depression. There are also systematic changes that were occurring and that affected pediatric CL psychology during this time. This included influx of patients with COVID-19, limitations and questions about PPE and who should be having access to that, efforts to decrease unnecessary contact, and also the risk associated with the main form of intervention, which is talk therapy with patients, and the risk associated with being in close contact and speaking with patients in that way. The aim of this study was to collect information on how pediatric CL psychologists were providing mental health care during the emergence of the COVID-19 pandemic, mostly in the US. And there were several key factors that led us to want to examine this. One was the uniqueness of CL in medical settings compared to traditional mental health settings, and really no precedent for how this care should be given. There was also the extreme stressors that were being experienced by the children typically under our care, as well as the significant mental health implications, both for the pediatric patients we were serving, as well as the providers we were working with. And it was hypothesized that there would likely be an increase in telemedicine as an alternative healthcare service delivery method. Traditionally, pediatric CL psychology has not used telemedicine, although its efficacy has been shown in other settings, including outpatient mental health and increasingly with medical populations. But there was really no system in place or precedent for using this as the primary form of service delivery within the hospitals. We recruited psychologists through the American Psychological Association's Division 54, the Society of Pediatric Psychology. They mainly came from the CL Special Interest Group as well as related special interest groups. Data was collected from April 6th to April 20th, which we now know was one of the, we think of as like one of the early phases of the pandemic in the US. Questions included fixed choice and free response questions, and analysis was done both using standard statistical methods as well as using content analysis with an iterative coding process. Overall, we had 51 participants. This was only about 18% of our membership, so pretty low, low turnout, but this was also a time of really significant changes for people, both personally and professionally, so we're not surprised by this, turnout. The majority of our participants were female. This is reflective of the field of pediatric psychology. The majority were also licensed psychologists, and then other participants included trainees actively seeing patients, social work, and psychiatry. And they had really varying levels of experience. The mean was about 8 years being licensed, but ranged from unlicensed professionals to being licensed for 35 years. They also served a range of specialty areas. The majority covered almost all medical population, or almost the majority covered medical populations throughout the entire hospital, and then also had subspecialties. And the majority worked with children between the age of 0 to 21. They mostly were working in freestanding children's hospitals, and then also were on pediatric services in general hospitals. The small group was in a primarily outpatient setting. So we saw pretty significant changes in how healthcare services or how CL services were being delivered at this time. The red is a pre-pandemic. So pre-pandemic, people were reporting that almost 100% of their patient care was face-to-face. A very small percent, like 3.2%, reported that a very small portion of their patients, about one patient within their caseload, they saw through telemedicine. And this shifted in this time period to only about 9.8% doing face-to-face for the majority of their work. The majority shifted to telemedicine as we had hypothesized. 82.4% reported that almost all of their cases were being seen in this way, with some still reporting some face-to-face, as well as some people also reporting that their services had been paused due to what was going on and the stressors on the system. A number reported that they were using multiple modalities, with telemedicine being the primary one. They also reported on their perceptions of how quickly services transitioned within their settings, the level of support they got, and their perceived reactions of the patients that they were seeing. They reported that generally they were receiving moderate levels of support and the speed was sort of at a moderate level. And they felt that generally the patients were pleased or neutral about the shift in service provision, but that was based on their own perceptions, not direct patient report. In terms of the qualitative data that we collected, which were written responses to open questions, the main themes included both benefits of changes in service delivery as well as challenges associated with it. Within the category of benefits, there were 3 main themes. This included safety. People felt that they were really able to improve patient safety by not having direct contact with them and providing services through telemedicine. They also felt that provider safety was increased as there were less people on site who could potentially transmit or lead to increased infections. They felt that there were also clinical benefits. Telemedicine gave them more flexibility. They were able to see patients at times that worked better for the patient as opposed to sort of more structured clinical hours. They were also able to easily come in and out of telemedicine appointments as opposed to sort of running around the hospital looking for patients or trying to find time to meet with them. They also felt it was more efficient for similar reasons, and they felt that it improved access to care. So this included both patients who were discharged from the hospital and lived further out from the setting and weren't able to come back in for in-person care. They were then able to access them through telemedicine. And also people reported that they were able to cross-cover and help their colleagues who were experiencing sort of increasing volumes of patients by using telemedicine. Organizationally, they felt that this allowed the continuity of services. Very few reported that psychology services, CL psychology services, were paused during this time, so they felt that that was a benefit, and that it also sort of emphasized the importance of mental health and psychology during this time of great uncertainty. Here are just some quotes that sort of illustrate these main themes. One person said, It has been extremely convenient for our families. They appreciate saving time and resources while being able to see a psychologist. A lot of people reported that families no longer have to worry about parking, increased time in the hospital, or other costs associated with coming for psychology appointments. Others said, telemedicine is permitting our team to remain reasonably protected and safe during this time so we can continue to serve our healthcare system. So providers were able to continue to see patients and didn't have to worry about infection, and also didn't have to use PPE that would be better used by people who their jobs really require direct patient care or direct contact, physical contact with patients. Additionally, some providers said there was a deepening of the bond with the medical team as they worked through challenges and decisions related to COVID-19. It's also important to note that there were various challenges that were associated with the changes that were occurring at this time. They fell into the main themes of clinical, technological, and organizational. So in terms of clinical, this really was unprecedented in terms of bringing telemedicine into the setting. So there were a lot of questions regarding implementation, ranging from what services to use, how telemedicine should be done, how to bill, who and why should people get it. There's also a reduction in patients, I think, especially as patients were urged to stay home unless there was a medical emergency. And people also had to deal with their own personal life circumstances and home schedules and balancing clinical care with that. Technological changes were also reported. Patients had difficulties accessing telemedicine services, especially if they had limited technical or technological literacy, if they didn't have access to devices. A lot of telemedicine services required patients having a certain type of device, which they didn't all have. And then also there were questions or difficulties related to internet access and things like that. There's also difficulties related to provider access and providers having the technology needed to perform telemedicine. Organizational challenges that were highlighted included people feeling there was decreased communication with colleagues, and in pediatric CL psychology, you're really responding to the needs of the primary medical team. So this is sort of like a mainstay of the practice that was difficult. Also unclear communication from leadership and just dealing with staff distress that they were noting in their day-to-day work. So some quotes that illustrate this are, one challenge is getting patients to come to appointments or pick up their phones. Having ways to connect with patients, as many do not have technology or their phones are disconnected. So as opposed to the past when psychologists could just go in and just find the patient literally in their hospital room, they now have to rely on a little bit more of the patient's efforts to engage in these services. There's also difficulties connecting with our colleagues is more challenging. There's a lot of texting, but much can get lost in the text messages. It is not like face-to-face hallway discussions, team meetings, or care conferences. Additionally, someone stated, it seems to be more challenging for patients who have specific presenting problems that make telemedicine more challenging, such as patients who are in pain or patients who have recently suffered a significant trauma. And this was a big discussion within the CL pediatric psychology world, just like if telemedicine is really appropriate for people who are experiencing these really challenging situations, such as like end of life, disclosure of difficult news and other things, people with certain developmental disabilities, whether or not telemedicine was really appropriate to engage with those patients. So in conclusion, this study showed that overall pediatric CL psychology can be transitioned and can be transitioned quickly to telemedicine, but there are a lot of challenges that still have to be addressed. One of the main things is the collaboration with colleagues, as that is really a key part of CL psychology. And the findings of our study suggested to us that an algorithm could be helpful, both at that time and especially going forward, just in determining whether and how services should be delivered, both during the current time and if there are similar future situations. So in this algorithm, we propose that there are certain factors that people should consider when deciding what healthcare service methodology they should use. These include patient factors, whether the patient is immunocompromised, on contact precautions, COVID status, what the actual question is that the psychologist has been asked to address, the acuity of the concern, and whether or not the family and parent is assenting or consenting to the consult. Other institutional factors that should also be weighed include PPE and overall availability of it, what the policies are in terms of telemedicine, and making sure that any services being used are HIPAA compliant. So then given those different factors, sort of pausing to determine whether the risk of face-to-face visit outweighs the benefit, or whether the benefit of face-to-face visit outweighs the risk. And if the benefit of face-to-face doesn't outweigh the risk, we would say that telemedicine would be appropriate in the way to go. And if it doesn't, then we would say face-to-face and just following different COVID safe parameters that have been established. So looking towards the future, this really accelerated the field of telemedicine within CL. There are a lot of things that are still being still being figured out, everything from billing to continuing to figure out what telemedicine provider to use and things, telemedicine like system to use and things like that. While it both has the potential to close gaps in access, including getting mental health services both to patients who might live far away from the hospital and also potentially to settings that don't have an on-site psychologist, having collaborations across settings where they then could have access to mental health care. It also has the potential to increase gaps in access to care, especially for those who don't have access to things such as technology, internet access, or have decreased overall internet or technological literacy. So it is really important to keep an eye on that and to sort of try to decrease these disparities as much as possible, especially as the pandemic continues and the field of telemedicine continues to gain popularity. It's also future research sort of looking at the patient perspective of this experience is important, as well as overall efficacy of services delivered in this manner, as well as how our colleagues and other people within the hospital are perceiving and accessing these services. So to thank you for your time and some of my collaborators on this project.
Thank you for a wonderful presentation, and I think we have time for a few questions. Zhangyu Guo. Zhangyu, you have to unmute yourself. I guess not. So actually, I have a question myself as the father of 4 daughters. So we've seen a significant increase in the use of devices for purposes other than learning, or of course telemedicine. And so I'm just wondering, from the perspective of the kind of studies that you're doing, whether this seems to be a reasonable way for children to de-stress, or whether this actually is creating potential long-term sort of consequences or bias in their ability to establish personal relationship. And so, you know, maybe this is something that would be interesting to hear your opinion on.
Yeah, I think there's a lot of talk about the use of technology and about screen time, which prior to the pandemic, it was sort of universally known that we were trying to decrease that in individuals, especially in children. And now that everything is on screens and a lot of the social interaction, it has to be on screens, we've really had to shift how we're thinking about it. I think it depends on what people are doing with the screen. So I think if a kid is like chatting with a friend or playing a game with a friend and getting that peer interaction that they're not otherwise going to be able to get, or they're accessing school, or they're accessing health services, if they're accessing something that there's really no alternative for them to get, I think it's sort of like, it's like better than nothing, or better than them just like sitting in their room doing nothing, or like mindlessly playing a game by themselves on their phone. I think other times, yeah, if they're just like attached to the phone, like reading social media all day, or playing games by themselves all day, or shopping, that's a time where I would say, okay, you want to probably decrease that and try, if there are alternatives, like, an alternative in that case could be like going outside or interacting with family members. So I think sort of thinking about what is actually happening on the screen, as opposed to like following some of these universal thoughts and rules about screen time in general is good. And then of course,
I was wondering
like,
if anybody has done a study on sort of potential increase of psychosis in children that tend to spend more time than normal on these devices, or whether, there's no obvious, change. The other question I want to ask you, since there are no additional questions that I can see here, is there's been obviously initially significant resistance to sort of learning remotely, right? And now it actually has worked not horribly. It's children are engaged, and especially when there's telepresence at the other end. So what we call the synchronous learning has not been completely a failure. I was wondering whether you think that this may actually, in the long term, change the way we attend schools, because a lot of people, for instance, may not even need to travel to a school if this is not happening.
Yeah, I definitely think there are going to be long-lasting changes. Actually, at the beginning of things, I thought, oh, for my like oncology, hematology patients, this is going to be great. Like they're going to get so much more education than they were going to typically get, because they weren't able to attend in-person school. So I really thought like this would be really positive, especially for certain populations, like you're saying, who can't get to school. I think also, like you're saying, it's sort of like, it's not a universal thing. Like virtual school is so now such a vague term almost. Like virtual school is looking so different across different districts and countries and settings, that I think, like you're saying, sort of figuring out what is working in virtual school and maybe like capitalizing on that to increase access, lead to other opportunities and things like that. So like,
I guess it'll be very interesting to see whether students' performance is going up or down at the end of this calendar year, and this academic year, to see whether the impact can be measured quantitatively.
Yeah,
So,
yeah.